First-degree heart block may occur in patients who have no history of underlying heart disease, and it is sometimes seen in young athletes. This delay in conduction may also be seen in patients who are taking prescribed medications, such as beta blockers, calcium channel blockers, and digoxin. If a patient has been diagnosed with an acute myocardial infarction, you must be particularly alert and carefully monitor and closely observe the patient for the development of more serious heart blocks. You should note that the heart rate at 74 beats per minute, the rhythm is regular, P waves are present and upright. The PR interval is 0.24 seconds and the QRS is 0.04 seconds. These findings should validate first-degree heart block. Remember that a prolonged PR interval is the hallmark of first-degree block and is most commonly the only variation in the EKG strip. Also remember the first-degree blocks looks very much like normal sinus rhythm, but the PR interval is greater than 0.20 seconds. Remember, always monitor your patient clinical condition. Second degree heart blocks, atrioventricular functional impairment in the conduction system. The conduction can be delayed, intermittent, or absent. The first type of the second degree blocks is less serious than the second type because bradycardia is less likely to be present and because cardiac output is less likely to be seriously decreased in a second degree type 1 block. The variety of names assigned to the two types of secondary degree blocks are those of the two physicians who initially identified and described these heart blocks, Karel F. Wenckebach, 1864 to 1940, a Dutch-Austrian physician, and Waldemar Mobitz, 1889 to 1951, a German physician. Both were instrumental in the research, classification, and investigation of these two types of heart blocks. Second-degree atrioventricular block, or Mobitz type 1, or Wenckebach, is a progressive prolongation of the electrical impulse delay at the AV node, produces an increase in length of the PR interval in second-degree AB block. A characteristic cyclic pattern is produced. The PR interval continues to increase in length until such time as the impulse is not conducted or a QRS complex is dropped. After the dropped complex, the PR interval resets, and the pattern is repetitive throughout the duration of the rhythm. Because of the drop beat, the impulse does not reach the ventricles. Therefore, ventricular contraction does not occur. The ventricular rhythm is irregular, but the atrial rhythm remains regular. Secondary degree Mobitz type 1 heart block is also referred to as Wenckebach phenomenon, or simply Mobitz type 1. Mobitz 1 may be caused by abnormal conduction of the electrical impulses at the AV node and precipitated by the AV node ischemia, digitalis therapy, or increased vagal tone. It may also a complication of an inferior wall myocardial infarction. Note that this rhythm is usually transient, most often benign, and will often resolve without intervention. You should note the progressive prolongation of the PR interval until the point of the QRS complex does not appear. You should note that heart rate of 48 beats per minute, the rhythm is irregular, P waves are present and upright, and PR interval progressively prolongs until a QRS complex is dropped, and the QRS is 0.04 seconds. These findings validates second-degree heart block Mobitz 1. Second-degree AB block or Mobitz type 2 is a more serious dysrhythmia than either first-degree block or Mobitz type 1. This is because type 2 indicates an increase of progression to third degree or complete heart block. Mobitz type 2 occurs when there is an intermittent interruption in the electrical conduction system near or below the AV junction. To understand this dysrhythmia, you should understand that the SA node is functionally unimpaired. In other words, the SA node is generating electrical impulses at regular intervals. Therefore, you should note that P waves will occur in a regular pattern across the EKG strip. You should also note, however, that some P waves are not followed by a QRS complex because the impulse is completely blocked in one bundle branch and periodically blocked in the other bundle branch. These blocks are referred to as bundle branch blocks. We refer the AV node as the gatekeeper to the ventricles, so it may be helpful to remember that in Mobitz type 2, the gate closes at regular intervals. When the gate closes, the impulse cannot be conducted through the bundle of His to the ventricles. Thus, no QRS complex is produced. Second-degree blocks are often referred to by the ratio of P waves to QRS complexes. This ratio may vary or be constant. The ratio of P waves to QRS complexes is often 2 to 1, 3 to 1, or 4 to 1. It may be easier to remember that an EKG strips or Mobitz type 2 may present as the appearance of 2 P waves for every QRS complex, 3 P waves for every QRS complex, or 4 P waves for every QRS complex. Mobitz 2 represents a complete block to one of the bundle branches and a partial block of the other branch. It is because of this conduction disorder that the QRS complex will often be widened, greater than 0.12 seconds. Characteristically, this type of heart block will produce PR intervals that are regular in length for conducted beats, more P waves than QRS complexes, and a pattern that depicts intermittently absent QRS complexes. It is important to note that PR interval in Mobitz type 2 is constant or regular for every conducted beat. Recall that this occurs because the SA node is firing at a regular pace, but the impulse is blocked or is not allowed to be conducted at certain intervals. Whereas the atrial rhythm is regular, the ventricular rhythm is irregular because of the dropped up or non-conducted beats. Mobitz 2 may be associated with septal wall necrosis, acute myocardial infarction, acute myocarditis, or advanced coronary artery disease. Depending on the ventricular rate, the patient may be symptomatic or asymptomatic. If the ventricle rate is fast enough to sustain cardiac output at an effective level, the patient may not exhibit signs or overt signs or symptoms. In this heart block, it is more common for the patient to exhibit signs or symptoms of decreased perfusion. Third-degree AB block or complete heart block. Without a question, the most serious type of heart block. This is true because third-degree block may progress to asystole and because the ventricular rate is usually very slow and ineffective. The heart rate of the ventricles may not be able to maintain a sufficient cardiac output needed to sustain life. Consequently, complete heart block is referred to as a lethal dysrhythmia. In the truest sense of the term complete, the atria and ventricles are completely blocked or separated from each other electrically. There is no communication between the atria and ventricles, as they literally beat independently of each other. The SA node fires at regular intervals, producing P waves and its normal rate of 60 to 100 beats per minute, whereas the ventricles are paced by an escape pacemaker in either the junctional tissue or the ventricles. If the ventricular pacemaker is the escape pacemaker, the ventricular rate will most commonly be between 20 to 40 beats per minute. If the resulting QRS complex is narrow, the escape pacemaker is located in the junctional tissue. If the QRS is widened, the escape pacemaker is located in the Purkinje network. There is, therefore, no relationship between the P waves and QRS complexes. The PR interval will be variable in length. Some P waves may actually be buried inside the QRS complex and therefore not visible on the EKG strip. In this dysrhythmia, the gate actually closes and does not permit conduction of the initial electrical impulse through the AV junction or ventricles. This dysrhythmia is sometimes called AV dissociation because the atria and ventricles operate independently. Although many conditions can cause third-degree heart block, the most common cause is coronary ischemia. The heart block may also result from degenerative changes in the electrical conduction system with advanced age, acute myocarditis, myocardial infarction, or drug toxicity.